episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome, everybody, once again to another episode of our show with another really fascinating guest today, helping to create a better tomorrow on many different fronts. Today, we have the honor of being joined by Carole Fisher, who is the president for the National Partnership for Healthcare and Hospice Innovation. We're utilizing her experiences and deep familiarity with not-for-profit community-based hospice and palliative healthcare. She is charged with leading a wide range of activities for the member organizations, including developing strategic partnerships, meaningful collaborations, transformational innovations among the nation's most notable and distinguished end-of-life healthcare organizations. As a seasoned C-suite advisor, innovator, and public policy advocate for the past 35 years, Ms. Fisher has successfully led and transformed for-profit and mission-driven healthcare operations, developing significant experience in growing and transforming companies, developing people, and preparing organizations for various unforeseen and unanticipated challenges. She has significant experience in growing the market share, contracting with payers, building specialty provider networks, developing technologies, doing M&A, and is extremely well respected for her ability to merge cultures and teams together. Ms. Fisher is formerly the president and chief executive officer of Nathan Adelson Hospice, where she positioned that organization into a nationally known industry leader, respected for their clinical advancements and innovations. Was recognized for 8 years by Modern Healthcare magazine as one of the 100 best places to work in the country. Ms. Fisher has a bachelor's degree in social work from the University of Nevada, Las Vegas, attained her master's organizational leadership from Thayer University in Asheville, North Carolina, and serves as adjunct faculty member for Telehealth University and is a member of the board of directors for the Thayer Institute. Previously served on the board of directors for Mountain View Hospital, which was a subsidiary of Healthcare Corporation of America, Elizabeth Kubler-Ross Foundation, Health Insight, UNLV Health Law Program Advisory Board, and the Nevada Hospital Association. Carole Fisher, thanks so much for taking the time to come on the show today.
Oh my gosh, thank you so much for having me. You made me sound so important, Ira.
You are important.
But I also want to thank you for advancing this important conversation. So
yeah,
really appreciate your time.
No, I'm looking forward to this. This is a topic that we've not gone into too much, and I'm really looking forward to educating us about a very important topic that many of us might not think too much about. Carole, I'd love to just start off, as we typically do. I want to hand you the floor for a few minutes, really just to talk a little bit more about yourself. Take us back a little bit, if you would, just sort of, where you grew up, how you got interested in healthcare in general, and what brought you into hospice and palliative care. I think that'll set the stage for a lot of what we're going to be talking about.
Well, thank you for that. Yeah, so I grew up in Philadelphia, actually outside of Philadelphia.
Okay.
I know, I saw that. We have that in common. And we share some common community ties. Absolutely. And eventually made my way to Las Vegas, Nevada. And so I went into social work because I wanted to make a difference and help people. And that's just ever so important to me. So through my career in social work, I practiced a little, but mostly I gravitated towards C-suite positions. And they were positions in behavioral health care. They were positions running a large delivery system for an insurance company, and eventually into end-of-life care. And so I've been really fortunate throughout my career to really bring forward the principles of social work in all that I do. Making sure that we're not just helping patients and families in all that I do, but also helping employees, because that's ever so important to me. Yeah, so here I am now as the president for the National Partnership for Healthcare and Hospice Innovation. It's a wonderful organization. It's a member organization. We have close to 80 members, all community leaders. They are some of the oldest, largest, not-for-profit, mission-driven, I call them community-owned organizations throughout the country. And they are the most innovative, most impressive organizations I've ever seen. I'm inspired every day by their commitment to excellence.
Outstanding. And I personally, I have never, I thankfully to date had a loved one or had the experience of hospice care in my family. However, I did have a father that died of spinal cancer, and he had home care, and this was about 30 years ago. And so the main thing I remember was just pain, getting rid of pain with some high dose opiates, and sort of that was the nature of what he was going through. Hospice care sort of much broader now in terms of not just pain, various symptoms of different terminal diseases, but also the emotional side, the spiritual side. A lot goes on in sort of end-of-life care. Walk us through a little bit, if you would, sort of the 2021 definition of what hospice and palliative care is all about. And if you could just talk a little bit about the scope. I know you mentioned 80 some odd organizations. Talk about the types of organizations in your membership so we can get a general understanding of what sort of the lay of the land is like in the space.
Sure. Well, let's start with hospice and palliative medicine and the importance and the value of it.
Sure.
I always say hospice is what's right in healthcare, because we hear so many stories about what's not going well in healthcare. And when I talk about what's right in healthcare, what I love about the hospice industry and the palliative care specialties is that people are not just focused on the physical symptoms, not just focused on the pain someone may be experiencing, although first and foremost, those physical symptoms need to be addressed and alleviated. But in hospice, we take an interdisciplinary approach, which means, Ira, that we're bringing in all the experts at all the different in all the different areas of someone's life. So we're looking at the physical, we're looking at the emotional, we're looking at the spiritual aspects of someone's life, and we're really focused on the family and the loved ones, because that they're ever so important. It's not just the patient that's in front of us. So that's why I say, gosh, it's really what's right in healthcare. We bring together all the disciplines to establish really solid plans of care that engage the family and make sure that we're paying attention to everyone's unique individual wishes. We only have one chance, obviously, Ira, to die. And hospice, our mission-driven organizations, make sure that that one experience is done well, and that those family members and loved ones are really supported at the end and ongoing. So our members throughout the country, they care for, about 130,000 patients a day. Mm-hmm. About a third of those are on hospice. Some are on palliative medicine under the care of palliative medicine or advanced illness programs. We can talk more about that if you like. But in caring for those patients, their commitment is to make sure that everyone has their needs met, and they're very unique needs. I know that some people really want to be medicated. And some people, especially we'll use an example of a young mom, for example. She wants to make sure she's alert and present for her children. And so what's interesting from our members' perspective is that they're meeting people where they are, not where we are. And so we're always paying attention to what's important to a patient and their family members.
And, continuing along those lines, you mentioned it's such an interdisciplinary thing, and I know at your organization you have a chief innovation officer, a Dr. Muir, who is looking at the different innovative models and so forth that deal when you get into advanced illness, which is something that is an extreme specialty. Can you just talk a little bit about some of the innovation trends that you see? I mean, this is a new area to a lot of us and those listening, but from your position, when looking at the industry and having the connections to all of these organizations that take care of so many different patients, what are some of the things, whether they're palliative for pain or, I'm speaking out of term here, but take us on a little walk through as you think about, wow, it's 2021 now, what things can look like in the coming years, 5 years, 10 years out. What are some of the hot innovation topics as you see?
Well, it's a great question. Where we started over 40 years ago was really paying attention to people with cancer. Yeah. So as we've evolved and made ourselves necessary and relevant for folks at the end of life, we're seeing people with dementia, with Alzheimer's, with heart issues, with COPD, a whole host of things that really wasn't the intent of the original hospice benefit. And with that comes innovation, mainly, Ira, because the world is innovating. So the technologies are so much more sophisticated today in terms of medical interventions for patients. So we're always paying attention to keeping up with those innovations. That's just so important for us. So we're always at NPHI, which everything in healthcare has an acronym. So the National Partnership for Healthcare and Hospice Innovations, the acronym is NPHI. We're looking for how we can help our organizations move forward with best practices, making sure that we're collaborating with payers, making sure we're collaborating with relevant partners, and always moving forward so that what got us here won't get us there. So that's some of the thinking that's done. The most recent example is our partnership with the American Heart Association. We've come up with some best practices for people who are experiencing heart disease to support not just the patient, but their families and the caregivers and people that make those referrals, the providers, specialty providers in that care.
Excellent. And along those lines, one of the things that, I was trying to educate myself before we have had the chance to talk. You were active on a lot of the advocacy policy side of what's going on. One of the things I was trying to immerse myself a little bit in is sort of this 6-month issue, where there in your industry is a delay that may occur between when somebody should and when they ultimately get into hospice. Can you talk a little bit about this? Because I know this is sort of central to a main part of some of the policy stuff that you do. What is exactly this issue, and what are some of the things you're looking at to help remedy it?
Yeah. So one of the benefit was designed with a 6-month flexibility in mind that people at the end of life, at those last 6 months, would have access to hospice care and be eligible for care. And as we've seen the growth in the industry, specifically with the for-profit industry, we've seen a lot of people taking advantage of the benefit, so to speak. So we're really focused on not the time frame per se, but what's appropriate and who's eligible and what makes sense for that person as we help them at the end of life. So you'll see our members are really paying much more attention now to 2, 3, 5 years out from someone's end of life so that we can help them early on and make sure that they're receiving, while they're receiving perhaps aggressive treatment and curative care, that we're helping alleviate pain and suffering, bringing in the support from a spiritual perspective, bringing in support from the families also. But there's a lot of discussion about how to frame the benefit, who's eligible for the benefit. And what's important to us is that people tend to get better when they enter our care because we're helping them in a very unique and different way. So as they're getting better, that doesn't mean that they shouldn't be eligible for care, but rather taking a look at the holistic approach. So that's some of what you're learning about and what you're hearing about. Yeah.
And continuing along that line, once again, very active on the policy front, there is something that is called the Milliman study that your organization commissioned, studying the differences between what's happening in the nonprofit world and the for-profit world. And this was sort of a major set of findings. I was wondering if you could just take a little time, just talk about why the organization decided, why NPHI decided to commission this study, and what some of the major findings were, and how you're now leveraging these findings to in sort of optimizing everything that goes on in the industry.
Let me first say that anybody that works at the bedside is a very special person, regardless of tax status of that organization. But there are some real distinct differences between a not-for-profit, mission-driven organization and a for-profit. And so we were very interested in making sure that we understood those differences and that we could highlight them, learn from them, grow from them, and continue to develop from them. So some of those unique differences are we tend to be the safety net. We care for the most vulnerable and sickest people. So we've learned that. We've learned that we go to people's homes more frequently versus, first of all, home could be wherever that patient is, but we tend to go into homes, actual physical homes, versus going into a skilled facility where we do that work. But you'll see the for-profits tend to spend the most of their time in that arena because they can care for more patients, or it sure feels that way at one time, where we're investing our resources into people's homes where they're traveling from home to home across the city. Maybe they're caring for homeless, they're going into prisons. So we find that we're more willing to take on the most difficult, most vulnerable, no matter of location of care, not just the disease state. We also learned that we care for sicker patients. We provide more nursing visits towards the end of life. And so these are important distinctions that really show our value, our commitment to outstanding quality care, along with cost-effective care. Our goal is to always to keep people at home where they want to be and not send them kind of through the revolving door mechanisms of going back into a hospital, unless of course that's warranted. And our mission-driven members tend to keep people out of the hospitals, which is really important to know, Ira, because when you get back into that cycle of a hospitalization in a medical surgical facility, you're being poked, prodded, repeated treatments unnecessarily because of the fragmentation in healthcare today. So those are some of the things that we've learned along the way. We value our differences and our unique individual differences that our members have.
Talk a little bit, if you would, Carole, about the last year. Obviously, COVID was a major shocker to the world. Death stared many people in the face that didn't think and they were going to be looking at it. Talk about how the last year went in the hospice and palliative management domain. Obviously, we weren't, we're talking about pain relief here, but we're talking about respiratory care and so forth and so on. Any major challenges, opportunities that came out of the pandemic? And then a third part of that, sorry, I'm dumping this all on one question, but we talked on some past episodes about burnout in certain areas of the healthcare space. Talk a little bit about sort of what's transpired in hospice care on that front as well, if you would.
Yeah, well, first of all, I mean, I think one of the things we learned, our providers learned, is always to be prepared for the unexpected. And no one could have expected not just COVID, but, we all thought, oh, maybe a month, right? But here we are, close to a year. We really, our members really had to dig deep in terms of getting equipment, being prepared, getting their employees prepared. Many of our members repurposed inpatient facilities, which is a significant difference too. Ira, most for-profits don't have inpatient facilities. They'll go in and lease a unit from a skilled facility, or we have our own unique freestanding buildings that are designed just for end-of-life care. So many of our members repurpose those just to care for COVID patients. So it's been a year of great learning. It's been a year of incredible stress and strain. Caregivers at the bedside, extremely frustrated, extremely tired, because they were seeing things they've never seen before, experiencing things they've never experienced before. A great example is those patients that are in or were in facility settings. We were denied access. We couldn't get in to help them. So families couldn't get in either. So you're watching people die alone, afraid and pain. And it just doesn't speak to who and what we do and who we are. So lots of learning, lots of fallout, lots of opportunity today. I think as we look today where we're headed, I don't think you'll ever see another hospice organization, one of our members, be unprepared with equipment. Who would have figured they would have needed so much protective equipment on hand? And so that's just a lesson in itself. Also, the technology aspects, the pivoting. Many of our organizations will talk about the fact that they had to pivot rather quickly with their technology and how they were communicating. And so having these types of meetings now, you and I are talking over Zoom, it's very commonplace, but over a year ago it wasn't. So teams were meeting on Zoom. Many of our organizations have held bereavement sessions, support groups on Zoom, and people have had to adapt to the ever-changing complexities that we have faced during COVID. I always say great learning. No problem should go unnoticed as an opportunity to improve upon what we do each and every day. But it's been very challenging. And at the same time, while we're going through COVID, we're still responsible to make sure that we're moving our organizations forward in a time of great change, in a time of great stress. So it's been the most challenging of times for our members, and appreciate you recognizing that and speaking about that. In terms of burnout, I can tell you that MPHI held different forums for people. We were very engaged in making sure to support our members, to provide an avenue of support for our members over Zoom, of course. But that became really important. Gosh, I watched so many of our programs get creative. They would have drive-by parties or drive-by sessions where people would go through in their cars and they would just show their appreciation that way and maybe have a token of some type of gift. So we've seen a lot of what our members have had to do and improvise, which is all part of leadership, improvisation, but they've had to improvise on how they cared not just for patients and families, but for their employees too, their workforce. Yeah. Challenging times.
Yeah, it's I can imagine. I can really imagine.
And I hope I answered that question.
Yeah, spot on.
It was like a three-part series there. So
no, I'm glad you picked all three of them off. It was beautiful. Thank you.
Yeah.
So, this will only be a two-part. Well, no, I'll carve this one up because there's a lot of really interesting themes here. Obviously, equity is another major theme of the last couple of years, a big theme in healthcare in general. I noticed that you have Miss Altonia Garrett, who is your health equity advisor now at the group. Talk about a little bit of what's going on specifically in hospice and palliative care in terms of the inequities, and then what you're looking at in terms of remedying them with sort of new tools, innovations, and so forth.
Hard to believe that today marks 1 year since the George Floyd, unfortunate, just horrible incident. That really prompted us, our leadership team, to say, look, to know better is to do better. And are we really making sure that everyone has access to care? And while many of our programs have very specific and unique programs for hard to reach populations, what we've decided to do at MPHI is to take it a step further. So we're actually working on an Institute for Health Equity, where it's a twofold kind of overarching goals, Ira. One is to make sure that every person in this country has access to quality end-of-life healthcare, no matter of color of skin, no matter of religion, no matter of sexual orientation. Everybody should have access. And today they don't. I mean, there are many pockets of communities that just don't access end-of-life care, and we can talk about some of that in a second. But the other overarching goal is to make sure that our workforce reflects the diversity that of the patients that we see. Altonia Garrett is an amazing woman who is working with us to move those efforts forward. And she's just an advocate, expert in that area. And so I'm glad that you mentioned her. She's great. But we're very committed to making sure that MPHI is a leader in that space because we understand about the unique aspects of people's lives. And so now it's just strengthening that understanding to make sure that we're really caring for everyone, and making sure that we never refuse anyone because they can't pay or because of color of skin or and we do that now. We just want to do it better. Yep. So yeah. Hopefully I answered those questions. I'm passionate about this issue. It's an important issue. Yep. It means a lot to us. And it going back to families, different cultures care for their families in different ways. And so it's not uncommon for people to say, well, I really don't need help. I've got this. I can care for my family. And in fact, understanding those cultures better, representing those cultures better is really our quest and our goal, to make sure that everyone has access to quality end-of-life healthcare.
Yep. And now putting a lot of these policy and advocacy topics together, we have equality, and we have the payer situation and access and so forth. You're working on a lot of stuff. What, if I get you up now to Capitol Hill or get you into the White House, what are some of the things? Obviously, we just came out of a major election, and there was only a few key topics, and I don't know if palliative care was up there, but what do you want to talk to Biden about once you get in the White House? What are the things you want to hammer home that we really need to do as a country for this particular industry? Is it more funding for end of life care? Is it what are the real issues that you want to get across to the major decision makers there on Capitol Hill?
Well, we're really fortunate because we're liked by both parties. So Republicans and Democrats both understand our issues. So We're really fortunate. Good. We're also really fortunate that President Biden understands grief and loss because of his personal experiences, and he certainly appears to be a very strong advocate of the work that we do. There's several things that we're interested in. There is no payment mechanism today for palliative medicine. So when I talk to you about, moving out a little further out into someone's life, not just those last several months, those last 6 months, who can we count on financially to help us pay for that? Because we know that the quality outcomes are there, and we know that we actually reduce spending if it's done well. We're also very interested in making sure that we're audited fairly and equitably, and that isn't always the case right now. There's a lot of movement in the fraud and abuse area, and that becomes relevant to us, Ira, because there has been such growth in the for-profit industry that sometimes we pay the price for that in the mission-driven, not-for-profit organization. So I'll give you an example. I mentioned before that we typically have an inpatient unit. Many of our members have inpatient units. Well, if you look at utilization patterns, you'll see that we have higher spending because we have inpatient units. And the government is eager to look for fraud and abuse, which I understand. But they start targeting the wrong demographics of information. So they may say, oh my gosh, they have so much general inpatient use. What's up with that? Instead of getting educated and looking at the broader story. And the broader story is absolute incredible growth in this industry. And it's not for profit. It's for profit growth where there's a lot of opportunity to make money. And there's a lot of private equity investing in this space. So we're seeing, we're sometimes victim of that fraud and abuse, those audits. So we'd love to see some kind of guardrails around that. We'd also love to see, on a whole other topic, telehealth and some of the opportunities with telehealth that were afforded to us during this time of the pandemic. We'd never want telehealth to replace the benefit. Sure. That would be just a mistake. But there certainly are some, with some proper guardrails, really good use of telehealth, especially in rural communities or where we have to check in with patients for like regulatory kind of check off a box, that would be a great use of telehealth, where we would save some time putting a physician or nurse practitioner or someone in a car to go to someone's home. So yeah, we're really pleased with the Hill today, and they're very receptive. We just had a 2-day event, Hill Day event, and both sides of the aisle are just so supportive of the work we do. So we're really fortunate with that.
Excellent. Let's go into the lightning round now. Beforehand we chatted about some of these topics, but just love to get, these are more tangential to the core of the hospice and palliative care space, but love to get your top line couple minute thoughts on each of these, because you see these in the press a lot lately, and just like to with your expertise. And the first on this list is the topic of death midwives or death doulas, which seems like a role that we've been hearing a little bit more about in terms of helping families cope with the theme of death, and sort of helping create plans spiritually, psychologically. Is this role synergistic with sort of what you do? Is it a separate type of thing? What's your top line on death midwives?
I think you're seeing a lot of movement in this area, because what we're seeing is that people are starting to talk a little, it's still reluctant, but starting to talk a little bit more openly about death and dying. And I think especially as we're coming off of a COVID pandemic, or still working through it, people are having conversations that they shied away from before. So death doulas, that midwife kind of role really recognizes and supports someone so that they can either be the person that's actually experiencing death, or they can be the loved ones that are grieving, and it's support to help those families, just like hospice, just like we do in our mission-driven organizations, very similar, but it's just becoming a little bit more formalized. I am thrilled that people are embracing the discussion, because that's what's most important. We love to celebrate birth, don't we? And I have a new granddaughter, and she's 18 months, and it's wonderful to celebrate her. And then we tend to shy away from talking about my mother, who's in her 80s now, who, knock on wood, is in great health, but how do we forward those conversations about what she wants at the end of her life, and how do we have those? And so families find that very, very challenging. And so I think death doulas really help move that conversation forward. Yeah.
Excellent. The second on the list, obviously, we've seen a lot last several years. Psychedelics and hallucinogenic substances, once forbidden in Schedule I, now making their way back into the modern pharmacopoeia. And one of the main indications for a lot of these that people are studying are fear of death, reducing the significant anxiety that comes from impending death, end of life. Your thoughts on psychedelics and the development of these therapies for use in the hospice palliative care environment?
Yeah, I think it's a terrific question. And I am of the belief that anything that will assist people at the end of life should be considered. That being said, we want to make sure they're safe. We want to make sure that, that treatment intervention is the right thing for that person. So it's such a new space to be talking about. And I haven't really heard my colleagues talking about that space, but I am very aware, because of my behavioral healthcare background, that those types of interventions are being used to help with anxiety and depression. And so there very well could be some great application in end-of-life care. I'm not going to sit here and say yes or no. I just am watching the progress and the innovations that are occurring. So I think it's a great question, and I look forward to seeing the advancements in that area and how we might very well embrace them. Yeah, it's great thinking for my lightning round question.
Okay, no, that's perfect. Nothing wrong with that. One other in the lightning round. This is really just more of a general discussion, sort of fun facts type thing. But about a year ago, I got to spend time talking to Dr. Chris Kerr up in Buffalo. He's an end of
Isn't he
life.
great?
Yeah.
He's
And
great.
he focuses, as you know, on end of life dreaming. And, you know, these fascinating findings that at the end of life, when we think, especially with the deterioration of the mind, that our dreams should be more fractured and scattered and whatnot, he actually sees the reverse in a lot of patients where there's more clarity. And this not only helps bring sort of peace to the patient themselves, but the family. And there's a lot of sort of, I would call it spiritual, but there's a lot of concepts and ideas and meaning there that we can get into. But I'm just, you know, it's not as much a question, but are there other interesting in your members? I guess when you're at your meetings or you're getting together with some of these interesting practitioners that you talk to, any other interesting people, cases like that, you know, obviously this is really cool stuff. Maybe we'll study it more 5-10 years out, but any interesting findings that fun facts about end of life care that we should know about today, like Chris Kerr's work?
Yeah, I really applaud Chris's work. He's doing just phenomenal work. You know, I think we spend a lot of time talking about not what is, but what could be, and the possibilities and how to improve end of life care experiences. I am always reminded that people should decide for themselves what's the best intervention, as long as they're able to communicate for themselves. As I alluded to earlier, you know, whether it's that young mom who's taking control and saying, no, I want to be extremely alert. I don't mind if I'm physically uncomfortable because I want to be alert for my children. You know, to people who probably like myself, I'm not good with physical pain. That's why I've had one biological daughter. And, you know, never again, right? Do I want to feel that pain? So, you know, really making sure that we are always paying attention to the unique differences from person to person. And so we spend a lot of time talking about that. And how do you make sure you meet those unique needs? Dying's just such a spiritual journey, and it should be tended to with great care and attention. And I'm always in awe of the caregivers that have to put themselves, their bad day, aside and be very present for that person and at the bedside. And every person is just so unique and different from each other. So we have a lot of conversations about that, and equally important, and I hear our members talk about making sure that each patient that we care for is not a number. You know, I mentioned 120, 130,000 patients a day. All those people have a story. And they have a story that is very significant. They were key contributors to many lives around them. So we never want to lose sight of that either.
Excellent message. Appreciate that. Carole, we've gone through quite a lot, and I really appreciate you know, you being so open and talking about every one of these issues. If I've missed anything, any upcoming events, talks you're going to be giving, conferences you're going to be at, I'd love to just hand you back the floor for a couple of minutes just to mention anything that you really want to, because it's such a fascinating area. You have such a wide portfolio of things you're working on. Please take the floor. If I've missed anything or anything else that you want to mention, people shout out to, please.
You know, gosh, thank you for asking that. I think, and I don't have my toll-free number with me. I can't believe that. We have a toll-free number, and I'm going to make sure you get that. For people to call if they have questions, if they have issues, if they have concerns. What I would like listeners to really hear is that our mission-driven members are here for the right reason. And they're here because they understand the importance of life. They understand the importance of making sure that families and loved ones are well cared for too, and equally important. And so no special event. If I could get any message across, it would be the value that our MPHI members have the great work that they do. They are significant members in their community. Many are 40 years plus. They're the experts in providing care at home, which is really where most people want to be. We certainly have learned that through the COVID pandemic too. So yeah, just understanding that we're here for them, we support them, and I will promise to get that MPHI toll-free number for you so that you can list it on here. That'd be great.
We'll put it in the bio.
I should have it memorized. Don't tell anyone. Well, now everyone knows. It just listens. And
I don't even know. I don't even know my home phone number nowadays.
That's the problem. Ira, thank you so much. It's a privilege to be on here and appreciate your interest.
It was a great time, Carole. And I just, for everybody that's going to be listening to the episode on the podcast or watching on the YouTube channel, you've been listening to Carole Fisher, President, National Partnership for Healthcare and Hospice Innovation, as NPHI. We'll put the links in the bio. Carole, once again, I just want to thank you for taking the time out of your schedule to come talk to us. Thank you for everything that you're doing in this extremely important area. And as we say on our show, thank you for helping to create a better tomorrow through what you're pioneering, your innovations. Very, very inspiring stuff.
Thank you. Thank you so much.